Right, hopefully you should all be able to see the slides. I'm particularly enjoying reading the chat box actually at the moment, firstly where everyone is tuning in from. And also I saw a comment about amber nectar. So I see some people have got the alcoholic drinks out, which hopefully won't need that for this presentation. So obviously, good evening, everyone. Thank you for tuning in, and thank you for CPD-Me for inviting me back. We're going to be looking at acute abdominal pain for this webinar, which should go on for about the next 45 minutes or so. Welcome back if you've listened to my previous webinars, and if this is your first time joining us, thank you. So let's get started. So obviously my name's Chris. I'm a junior doctor. I work in the north of England, currently for a medical school, but I'm starting GP training next week. This is Maggie the dog. So those of you that have been on my previous webinars will know Maggie always makes an appearance at the beginning of each presentation. So this is Maggie after enjoying a particularly long day at the beach, where she discovered what waves were for the first time. So if you've got any pictures of your pets, you can always, as Dominique says, share them on Twitter. So it's always good to see them. Fine, so let's have a think about what we're going to be talking about tonight. Obviously, abdominal pain is a massive topic, and we're not going to cover everything in one short webinar. Otherwise, I would bore you. It's also worth remembering that no doubt you as listeners all have different skill levels and are working in different practice environments, different scopes of practice, etc. So I apologize if this is maybe too basic or not applicable to your setting, but hopefully you'll get some learning points from the webinar. So we're going to discuss kind of the history, the examination, and some causes of abdominal pain. And I've got two interactive case studies for this session. So once again, those of you that have been on previous webinars, we've had slightly more case studies, but we're going to look at two in a bit more detail. And hopefully you'll find unpicking these cases in a bit more detail useful. I'm always open to any feedback. As we work through the cases, it's always useful to keep a note of potential diagnoses, so creating a differential diagnosis as we move through the case. So if you've got a pen and paper at home, you can scribble some thoughts down. And if you're listening to this as a recording, you can always pause the recording if you need more time to think. Great, so hopefully we all know what we're doing, and I will try and keep an eye on the chat box, although I'm not very good at multitasking, but I'll try. Right, okay, so the thing is that abdominal pain is really common, and I'm sure we've all assessed patients who are presenting with abdominal pain. It doesn't really matter where you're working, if you're working in a community setting, a pre-hospital setting, in a hospital setting, abdominal pain is very common. It's also, I confess, maybe not as exciting as some of the other webinar topics available. I appreciate that. And I'm sure some of you, when you go and see a patient with abdominal pain, maybe your heart sinks slightly because, there's not a really exciting piece of equipment you can use, or, it's just not the most glamorous of topic, is it? But it's really important to know about because it's such a common presentation and it's got a wide spectrum of severity. So all of us, I'm sure everyone listening to this webinar has experienced abdominal pain, and the spectrum of lots of us will have mild self-limiting conditions. But there is a spectrum of severity, and there are urgent conditions we need to be able to recognize. And then there is a subset of patients with abdominal pain who will have immediately life-threatening conditions. And picking up these patients is really important. Often they require urgent surgical intervention. So this is the problem, isn't it? We're seeing lots of patients with abdominal pain. How do we kind of weed out and sort out the ones that are, really serious and need to be seen straight away versus the patients that just have a mild self-limiting pain that's going to go away? So that's really difficult. And I think this probably comes with experience. You need to see lots of patients with abdominal pain and examine lots of abdomens. But hopefully this webinar will give you some theory to underpin your clinical practice. Okay, so we're going to start off with a little activity. So I haven't done this before in a webinar, but we're going to give it a go. So there's different ways of coming up with kind of a differential diagnosis or trying to think of all of the causes of a particular symptom. So let's say your next patient has got abdominal pain. what are the thoughts going through your head? How do you structure your thinking to cover all of the different causes of abdominal pain that could be occurring? That can be really difficult. So there's a couple of ways that you can think about diagnoses. You might have heard of something called a surgical sieve, and that's the vitamins C, D, E, F up the top there, which I haven't put on the slides, but you can Google it if you want more information. And this is sort of how we teach medical students. And for example, the V stands for vascular, the I stands for infective. So we get the students to think about, what are all the vascular causes of abdominal pain? What are all the infective causes? So that's one way you can think about it. But what I'd like you to do at the moment is we're just going to take a minute or so, and I've split the causes of abdominal pain by system. So we've got gastrointestinal, urological, gynae, vascular, medical. So maybe take a minute or so. If you've got a pen and a paper, scribble down these categories and just see if you can list as many causes of abdominal pain that fit into each of these categories. If you don't have access to a pen and a paper, you can use a note app on your phone, or you can just think about them in your head. I'm not marking you. I'm not a school teacher. So, but let's kind of spend about 30 seconds to a minute. I'm just going to give you a chance just to think about some of the causes of abdominal pain. So I'll just give you some time to do that now, and then we'll move on. Okay, I'm gonna move on because it's a Thursday evening, and no doubt we've all got exciting things to do after this. So if you need longer, I apologize, but you can keep scribbling. Let's have a look at a list that I've come up with. So I'm sure you will have got things that are not on this list, but that doesn't matter. So this is the list I was kind of idly thinking of when I was thinking about this presentation. So once again, I'm sure you've got things on that I haven't put on this list. That's fine. Lots of conditions can present with abdominal pain. But hopefully this just gives you an idea of the spread of pathology that can occur when you're assessing a patient with abdominal pain. And remember, there was that spectrum of severity that we were talking about. So they could have simple constipation, or they could have a perforated peptic ulcer. So these are two very different spectrums of severity. It's also really important to think about the other causes of abdominal pain that aren't gastrointestinal. So remembering, for example, the urological causes, we're thinking about a young patient with abdominal pain and groin pain, makes us think about testicular torsion. Obviously, the gynecological causes are really important to consider. The vascular causes as well. We don't want to miss a patient with a ruptured aortic aneurysm. And then finally, the medical causes. Sometimes we fall into a trap that kind of abdominal pain only has surgical causes, or causes that are, need to be dealt with by a surgeon. But remember that some medical conditions can result in abdominal pain. The ones that I think of are obviously epigastric pain as a presentation of myocardial infarction. But the other presentation I think of is, for example, a child with abdominal pain. I always think of DKA, and it's always important to check a blood sugar because, you can get these atypical presentations. So hopefully you've managed to pop down some of the things on this list. This was just an exercise to get you thinking about the breadth of conditions and how they cross different bodily systems. So really, when you're assessing a patient with abdominal pain, you need to be a detective. Now, actually, someone in the chat who, I'm not going to scroll down because I'll lose my place, but someone in the chat mentioned Sherlock Holmes. So whoever mentioned that, either we are telepathically communicating or you've seen my slides. But I like to think of it as when you're assessing a patient with abdominal pain, you need to be a bit like Sherlock Holmes. It's like being a detective. You have to have a systematic approach, and you have to try and pick up on clues, either in the history or the examination, to come up with a diagnosis. And actually, just a little factoid for you, in that Sir Arthur Conan Doyle was a doctor, so the writer of Sherlock Holmes, and he trained in Edinburgh, I think. And a lot has been written about the similarities between a detective story and a clinical case and that kind of deductive reasoning that you need to use in order to get to a diagnosis. So there we go, a bit of trivia for you. Okay, so we've talked about why abdominal pain is important, and we've hopefully listed some conditions that can cause abdominal pain, and we've had to think about some bodily systems. Let's get into a bit of history and examination. So I'm sure the history of abdominal pain is all about the pain, isn't it? It's a really important it's really important that you structure your pain history well. So lots of you will probably have been taught the Socrates mnemonic, but there are other mnemonics, aren't there? OPQRST or whatever. It doesn't really matter what you want to use. But Socrates is a good way of covering all of the areas of the history that you need when you're assessing a patient with abdominal pain. And the key questions really are obviously the site, where is the pain? But we want to know a bit about the onset. Was it sudden or was it a gradual onset of pain? The duration or time course is important, as well as the character and the nature of the pain. So just to give you an example of why the timing is so important, we've got some graphs here. So if you were plotting pain intensity against time, if you've got a really serious condition like you've perforated your bowel, your pain is going to come on rapidly and it's going to remain constant. Whereas if you've got a different type of pathology, let's say your bowel is obstructed or your ureter is obstructed and you've got renal colic, then this causes this colicky type pain where you get these waves of intensity which come and go due to the peristaltic waves. If you've got an inflammatory condition, so for example, you're sitting at home and your appendicitis is brewing away, then that's a very different pattern of pain to, say, for example, a perforation. So instead, the pain builds up gradually. So when you're taking a history of a patient with abdominal pain, you really want to try and tease out these intricacies about the timing of the pain, which can be really quite, sometimes patients get a bit fed up about why you're asking them so many details, but it gives you a clue to the underlying pathology. So I think, and these graphs are just a nice way of showing this. Fine. So we've talked about a bit about the time course of the pain. Obviously, the location of the pain is really important, isn't it? Now, I'm sure we've all seen diagrams a bit like this. This one, which shows you the different conditions compared to the different locations of pain, and lots of variations of this diagram exist. So the location can help. For example, we know that right upper quadrant pain is associated with biliary pathology. Right lower quadrant pain or pain in the right iliac fossa, we think of appendix. And in the left lower quadrant, we think of, for example, diverticulitis or ovarian disease, etc. So you need to have a bit of a knowledge of anatomy. Now, you'll be thankful that we're not going to talk much about anatomy in this webinar because it's a really complex topic. And in fact, I put a really simple diagram here from Wikipedia. But if you're interested, I really recommend getting a good anatomy book. My favorite is actually anatomy coloring books because they're really easy to kind of visualize and learning a bit about the abdominal anatomy, because that will help you understand, for example, why the location of abdominal pain gives you clues as to the underlying pathology. This isn't perfect though. We know that abdominal pain, especially visceral pain, which we're going to discuss in a minute, is often poorly localized. And I'm sure we've all had those patients that kind of really struggle to put a finger on where the pain is. And that is actually quite a good technique in your history, is to ask patients to point with one finger where the pain is. So let's have a think about pain in a bit more detail. So there's a couple of different types of abdominal pain that can occur, and there's a really complicated picture here, so we'll go through it, don't worry. So when we think about the different types of pain, you can have visceral pain. So this is pain from an inflamed viscera or organ, and visceral pain tends to be very poorly localized. And this is because the nerves that supply the organs, the viscera, are not really designed for sensing pain. you know, we don't need to know exactly which bit of our liver is painful. So therefore, the pain fibers are not well localized. And often they go in at several spinal levels in your spinal cord. So because of this, the pain from an inflamed organ is in the initial stages is very poorly localized. It often localizes to certain regions, and this gets slightly complicated. I'll just try and explain it. So you've got different embryonic regions. You've got your foregut, your midgut, and your hindgut. And you can Google this if you want to look into this in a bit more detail. And these are basically the embryological origins of our abdominal cavity. But the pain tends to localize to different regions depending on whether it's a foregut structure, a midgut structure, or a hindgut structure. So, for example, pain from a foregut structure tends to localize to the epigastrium. Pain from a midgut structure tends to localize around the umbilicus, and pain from a hindgut structure tends to localize to the suprapubic region. And this is visceral pain. Another type of pain is obviously somatic or parietal pain. So this is where you get irritation of the parietal peritoneum. So the parietal peritoneum is has much more innervation from spinal nerves, and it goes in at a particular spinal level. So somatic or parietal pain is really well localized. So patients can tell you exactly where it's painful when there's inflammation of the parietal peritoneum. Finally, there's the concept of referred pain. So I'm sure we've all heard about the concept of referred pain. For example, pain from an aortic aneurysm can radiate to the back. Pain from diaphragmatic irritation, for example, from blood in the abdomen or cholecystitis can radiate to the shoulder. And this is because some of the crossover of pain fibers from visceral pain. And this diagram, which is quite complicated, just gives you an overview of hopefully what I've just talked about, how you've got the difference between this visceral pain, which isn't well localized, or this somatic pain, which is well localized. So I'm sorry, I've been whittering on a bit about pain. If you're lost, I'm sorry. If you just Google it, you'll get probably a better explanation than what I've managed to give you. But the best way to understand this is to think about appendicitis. So think about pathology. So you're sat at home and you develop appendicitis. So what's the first thing that happens? Well, your appendix becomes inflamed. It starts to swell. There's an inflammatory response. And as this happens, the appendix is obviously part of the gut. It stretches, it becomes inflamed, and you feel the pain fibers fire, and you feel this as visceral pain. So you actually get pain in the umbilical region. So if you read the textbooks, they tell you that early appendicitis patients often have pain in the center of the abdomen, in the umbilical region. And that's because the appendix is a mid-gut structure. So as we have just talked about, mid-gut structures cause umbilical pain. Okay, so you've got a bit of central abdominal pain, but you don't think much about it because, hey, your appendix isn't located there, so you're not worried about appendicitis. So you sit at home and your appendix gets more inflamed, it gets bigger, starts to fill up with pus. And then eventually it becomes so inflamed that it starts to irritate the lining of the abdominal cavity, the parietal peritoneum. And it irritates the parietal peritoneum where the appendix is sitting, which is often in the right lower quadrant or the right iliac fossa. So suddenly this umbilical pain that you had changes, and you get this really sharp, severe right lower quadrant pain that's worse when you move about or take a deep breath in. And this is because of the parietal inflammation. So this is now you're experiencing somatic pain. It's really well localized. You can put a finger on it and it's really sore. So hopefully I've managed to explain this in a way that's easy to understand, but this is the difference between visceral and somatic pain. So once again, this is your history of abdominal pain, can give you clues to the underlying diagnosis. Good. So we've talked a bit about Socrates and we've talked a bit about pain. Let's have a think about examination. So I'm not going to go through the entire abdominal system examination, as we will be here for a long time. But as I'm sure you're aware, you can split the abdomen into 9 regions, or you can split it into 4 quadrants. And whichever system you're familiar with, feel free to use that system. It depends where you've been trained, but the quadrant system is relatively good in most situations. So this is for palpation purposes, but it can also guide your history. When you're thinking about asking patients where the pain is, you can ask them to point, and they might point to a particular quadrant. So this is a good starting point. We need to know our 9 regions or our 4 quadrants. But like any examination, you can gain a lot of information just by inspection. So obviously it's really important that you expose the abdomen properly. And there's lots of clinical signs which you may see, but one of the ones that's reasonably important is the location of different scars. So I just thought I'd show you some pictures of different scars that you might see in patients. And I'm sure, we've all been to the patient that says that they don't have any past medical history, but they're on 10 different medications. Well, this is a bit similar, isn't it? They might say, oh, I've got no past medical history, but they've got lots of scars on their abdomen. So maybe they have had surgical procedures before. So this is useful in the context of abdominal pain, because it can give you a clue to the patient's surgical history and to perhaps the underlying pathology. So briefly, we've got, for example, a subcostal scar, which is used, for example, in open biliary surgery. We've got a midline laparotomy, which suggests major abdominal surgery. There may be laparoscopic ports. Scars in the right iliac fossa could be an open appendicectomy, either a McBurney scar or a gridiron scar. A cesarean section might cause a scar in the suprapubic region. Looking in the groins, you might see scars suggestive of hernia. And then there's these various scars in the left lower quadrant, which might, for example, be used for a renal transplant or colonic surgery. So once again, this is really useful when you're inspecting as part of your examination. So we've had a little think about the quadrants and the regions, and we've had a little think about scars. Like I said, I'm not going to go into a huge amount of detail regarding abdominal examination, because those of you that use Geeky Medics will know that they have an excellent resource for clinical examinations. So I would really encourage you, after this webinar, to go and read the Geeky Medics guide on abdominal examination, and they've even got a video as well. Like most things, the examination involves spending more time looking at other things apart from the abdomen. Actually, the abdominal part is relatively short, but you can gain lots of clues, for example, from patients' hands, face, their skin, to the underlying pathology. So I've just put some suggestions on this slide for things that might be focused on the abdomen. So when you're palpating or feeling someone's abdomen, you might feel particular masses. So you may feel a mass, for example, in the epigastrium, in the right iliac fossa, in the left iliac fossa. We all worry about, for example, a pulsatile mass in the midline and whether that could be an aneurysm. You might feel what we call organomegaly. So you might be able to feel a liver, or be able to feel a spleen, or to be able to feel a kidney. And this could be a sign of pathology affecting one of those organs. We then worry about tenderness. So it's always useful to kind of try and localize the tenderness. So are they whereabouts in the abdomen? Are they tender? And then there are some more specific signs for what we call peritonism, so inflammation of the peritoneum. And if you read the textbooks, it talks about things such as rebound tenderness, where the pain is more severe when you let go of your hand compared to when you press in. And that's because the peritoneum springs back into place, and that's meant to be incredibly painful. There may also be guarding, which is that involuntary tension in the abdominal wall muscles due to inflammation of the peritoneum. So these are all signs of more serious pathology. And then auscultation of the abdomen, so using your stethoscope, you're listening for the presence or absence of bowel sounds, which can give you a sign as to whether there's any form of obstruction going on. So this is probably all I'm going to talk about as regards to examination. And to go and have a look at the Geeky Medics Guide if this isn't something that you do day to day in your clinical practice, as it's really important. If I had to give you one top tip for abdominal examination, one sort of takeaway from the webinar is try and, when you're examining someone's abdomen, don't be standing over them. So you want to get down to their level, and you want your forearm and your hand to be on the same level. So you don't want to be standing over them, just pressing down on their abdomen. It's much easier if you kneel down or crouch down and get down to their level, and then palpate the abdomen with your hand and your forearm level. It's a much more specific way of trying to localize pain, and it's a much better technique. So that's just my top tip. Fine. Okay, so now we need you to do a little bit of work. So I've been talking for a while. So in this webinar, I'm going to focus a little bit more on some of the investigations for abdominal pain, as I know not all of you will be working in settings where you've got access to investigations, but it's useful to understand what investigations are available. So maybe this is a useful point. If you want, you can scribble down some ideas on your bit of paper that you've got, or you can put some ideas on your notes, or if you want to type them in the chat box. And if you're going to type them in the chat box, it would be really good, as well as the investigation, why would you want to perform it? You know, what information is it going to give you regarding your patient? So has anyone got any thoughts? Let's see what all of us come up with. Someone has said ultrasound. Good. Yeah, so we use ultrasound in certain situations. Depends what you want to ultrasound, though, doesn't it, I guess? Okay, so there's a few things coming through. Someone has said speak to the patient. Yes. Let's imagine that we've done that. So we're just thinking about scans. All right, there's loads of stuff. Yeah. So people are giving a variety of things. So imaging, blood tests, and vital signs. So it's good that people are mentioning vital signs. So that's a really important investigation because you want to gain an idea how kind of physiologically unwell your patient is. I like that people are saying ECG. Yeah, so anyone who's got kind of upper abdominal pain or epigastric pain, or even back pain, you could say it would be useful to do an ECG. What else have we got? Yeah, pregnancy test, excellent, really important. So any kind of woman of childbearing age definitely needs a pregnancy test. There's an old adage, isn't there, in medicine, that everyone's pregnant until you assume everyone to be pregnant until you've proven otherwise. And then some blood tests. So people have said full blood count. Yes, that would be useful. And then some imaging. So CT scans, ultrasound, and plain X-rays. And yes, someone's put BM as well. Yeah, so blood sugar would be useful too. So the investigation list that I sort of came up with, I've split it into kind of bedside investigations, laboratory investigations, and imaging. So at the bedside, you obviously want to, perform routine observations. How sick is your patient? Things like urine analysis, urine pregnancy test, really important, capillary blood glucose, and then an ECG, as we've already discussed. Thinking about laboratory tests, so some of you may not be as familiar with all of these, but a full blood count, so looking at someone's hemoglobin level, are they bleeding? Is there signs of anemia? Urea and electrolytes, so renal function is useful to obtain a baseline if we're going to do anything or give any drugs which are damaging to the kidneys or perform any investigations. You may have heard of an inflammatory marker called CRP, or C-reactive protein, and this is a very good non-specific marker of inflammation. And if we're wondering something's going on with the liver, then we can do liver function tests. If we're worried about pancreatitis, then we can do an amylase or a lipase. And a lactate, which we would do on a blood gas, is a useful marker of hypoperfusion. And then if a patient with abdominal pain required surgery, then they would definitely need a group and save to obtain their blood group in case they require a transfusion. And then we can do what's called a bone profile, which gives you calcium and phosphate, etc. And that's useful to kind of rule out hypercalcemia. So hopefully this just gives you an idea of why you might want to order, certain laboratory tests. Obviously, you might not be able to do this in all of your practice settings, but this just gives you an idea of what investigations might be performed in a secondary care setting. And then from an imaging point of view, it kind of depends on what you think's going on. So you can do a rapid bedside ultrasound if you're worried they've got blood in their abdomen, such as a leaking AAA, or they've been involved in a traumatic event. Plain X-rays are not that good, to be honest. So when you see on TV or medical dramas, they get the diagnosis from a plain X-ray. That's not often done. We can do an erect chest X-ray to look for evidence of free air, which suggests that something in the abdomen has popped, like the bowel, and is leaking air. I'll show you an example shortly. And we can do an abdominal X-ray to look for obstruction. So is the bowel all blocked up? Ultrasound is good in certain situations. So it's good for looking at kidneys. It's rapid and non-invasive. Although a CT is better for looking for stones. And then an ultrasound abdomen is good for looking at biliary pathology. So this is, for example, your patients with right upper quadrant pain who you think might have mischief going on in their gallbladder. And then there's gynecological ultrasound, CT imaging, and then more specialized investigations such as endoscopy. And I've put an excellent link to a radiology interpretation site called Radiology Masterclass. So this is really good. If any of you are starting to, for example, having to interpret chest X-rays, abdominal X-rays, Radiology Masterclass is an excellent website. So just before we dive into our cases, I've just got a couple of images to show you, just in case you're interested. So this is an example of pneumoperitoneum. So this is an erect chest X-ray. Black is the lungs. You can see the heart in the middle. And here we can see what's called free air under the diaphragm. So this is the abdominal cavity where air has risen up because the patient's standing, and it's caused us to see this line here. So this is an indication that there's free air in the abdomen, okay, which is not a good thing. It means that hollow viscus, such as the bowel, has perforated, has popped, and that this patient is probably quite unwell. So that's just an example of how a chest X-ray is useful. Abdominal X-rays are pretty good at looking for obstruction, but then they're not completely diagnostic for other things. So here we can see obstruction of the small intestine, the small bowel. You can see there's these big loops of bowel sitting in the center of the abdomen. It looks a bit like a coiled spring. So this patient would probably have lots of abdominal pain, vomiting, and they wouldn't be passing any flatus or feces. And you can see these lines here these white lines completely cross the bowel. So that's how you know it's small bowel. And then here we see large bowel obstruction. So this is a bit more peripherally located. You can see this is the transverse colon. And you can see these haustral lines. So the lines aren't completely crossing the bowel. So this is an example of large bowel obstruction. Fine. So we've looked at blood tests. We've looked at imaging investigations. And we've talked about history and we've talked about examination. So let's have a look at some cases for the kind of second half of this webinar. So hopefully you found this useful so far. I hope you have anyway. So let's have a look at case one, which is obviously someone with abdominal pain. So as always, have a think about differentials as you're going through the case. You can type them in the chat box, or you can, I don't know, scribble them down on a bit of paper at home, or whatever you want to do. So this is our first case. So this is a 45-year-old who's got a, you know, not a terribly long history, about a 1-day history or so of worsening abdominal pain and vomiting. It's central, it's epigastric, and she initially thought it was just bad heartburn. It's pretty constant now though, and it's worsening. And she finds it improves a little bit when she's leaning forwards. So she doesn't really like it when you lie her flat in order to examine the abdomen. She's really worried about the vomiting now at the moment though. So the vomiting has now become, pretty constant, and she's struggling to tolerate really any fluids. She hasn't had any diarrhea, no fevers, no hematemesis. And she's had 2 or 3 episodes of upper abdominal pain over the past 12 months. And, she hasn't really gone to see the doctor, and it kind of got better on its own. So she's had this episodic upper abdominal pain. She's had her appendix out, no regular medication, and is normally pretty fit and well. Good. Okay, so there's our history. So you can already maybe start to think about the pattern of abdominal pain here and what's happening now. So this is a patient who's got kind of acute on chronic abdominal pain. So when you examine her, she's vomiting everywhere. So that's what you note down. She's got profuse vomiting. Her observations, she's a little bit tachycardic, a little bit tachypneic. And if you're drawing an examination of her abdomen, she's got severe tenderness in the epigastrium. So she's very tender in the epigastrium, but doesn't have any guarding or rebound tenderness. She doesn't have you can't feel any masses. She's got bowel sounds, and there's no hernia. And the rest of her examination is pretty much okay, but she's got some dry mucosa. So she does look as if she's got herself a bit dehydrated. And you can see that old scar in her right iliac fossa, which fits with her past medical history. Right, let me just have a look at the chat box to see what you've all come up with. So this is kind of imagining that you don't have access to any investigation. So we haven't got any investigations so far, but I'm going to show you some in a minute. So there's a few people have got the right diagnosis already, which is good. Okay, good. I'm quite impressed, actually. I'm quite impressed. Okay, so let's have a look at some investigations. So this is her. Let's say you do an ECG, and it looks absolutely fine, apart from a bit of a sinus tachycardia. So there's absolutely nothing weird and wacky on that ECG. There's no ST segment changes, no T-wave inversion. It's just going a little bit quick. Her urine pregnancy test is negative, and urine analysis, she's just got a little bit of a few ketones. She's been vomiting, and her capillary blood glucose is normal. And this is her X-ray. I don't know if anyone wants to hazard a guess at the X-ray interpretation. But it's, I'll give you a clue. It's normal. So this is a normal looking chest X-ray. Good. So she's got a normal X-ray, a normalish ECG, a negative pregnancy test, urine analysis that's not very exciting, and a normal capillary blood gas. So let's say we take her to the emergency department, or she's already in the emergency department or urgent care center, and she has some blood tests done. So let's have a go at looking at some blood tests. So once again, I apologize if you don't look at blood tests in everyday clinical practice, but hopefully this will just be useful for you. So what can we see here? So she's had a full blood count, which shows that her white cell count is slightly elevated and her neutrophils are slightly elevated. So this suggests some sort of inflammatory response. Her renal profile is normal, so she doesn't have a horrible acute kidney injury. But we've got some abnormalities in her liver profile. So these are her liver function tests. So what we can see here is that her bilirubin is slightly raised. Her ALP is quite significantly raised, and her ALT and her AST are also raised. And her CRP, which remember is a non-specific marker of inflammation, is also high. But there's a key investigation that's missing here. So if anyone can have a guess as to what absolute key investigation is missing here, put it in the chat box and we can all be impressed. And just to briefly mention about her liver function tests, if you are not routinely interpreting liver function tests, AST and ALT are kind of more intrahepatic, so they suggest inflammation in the liver. ALP is found in the liver, but it's also found in the bile duct and in the bone tissues, and it's typically raised in cholestasis. So cholestasis is where you've got problems, bile that's kind of the flow of bile has slowed down. So if your ALP is higher than your ALT and your AST, it suggests some sort of post-hepatic cause, such as a problem in the biliary tree. I hope that makes sense. If that doesn't make sense, you can Google Geeky Medics liver function tests, and that will give you a much more detailed explanation than what I've just given you. But this liver profile suggests that she's got some mischief going on in her biliary tree. And as for which investigation is missing, quite a lot of you have got this, which is really good. You know, this is a 45-year-old who's had recurrent right upper quadrant pain, who's now presenting with severe epigastric pain and vomiting. We absolutely cannot miss an amylase. And you do her amylase, and it's really high, 649. So what's the diagnosis? Well, in a lady with epigastric pain, vomiting, who's got an amylase, which is more than 3 times the upper limit of normal, the diagnosis here is that she's got acute pancreatitis. So this is pancreatitis. So let's have a look at that in a little bit more detail, as I'm sure you might have encountered patients who've had pancreatitis or who've had clinical presentations similar to this. So pancreatitis, as the name suggests, is just inflammation of the pancreas. That's, you know, like appendicitis is inflammation of the appendix. And with pancreatitis, you get in kind of inflammation of the exocrine pancreas, and you get injury to these, what we call these acinar cells. So very simply, your pancreas does 2 things, doesn't it? It's got an endocrine function, which controls your blood sugar, and that goes wrong in things like diabetes. And it's got an exocrine function. So it secretes lots of juices to help you break down food. Now, the enzymes that break down food are really destructive. So they'll break down anything, okay? Because you need to digest the food that you eat. So when you go to McDonald's and you have your £1.50 Big Mac, I think that's how much a Big Mac is now, due to the VAT cut, which is pretty good. But when you ingest that Big Mac, then you need to break down all of that processed food. So you need lots of strong enzymes. But what's the problem with storing these enzymes in your body? Well, they'll start digesting other things. They'll start digesting your own bodily cells. So the pancreas has a very clever mechanism to keep these enzymes inactivated until they're required in the gut. In pancreatitis, a problem occurs in the pancreas, and these enzymes are activated in the pancreas, and therefore they start digesting the pancreas itself. So it's called autodigestion, and this causes an inflammatory response by the body. And this inflammatory response can be massive. And as well as getting inflammation around the pancreas, you can get widespread systemic inflammation. And this can lead to multi-organ failure and shock. So what's the clinical presentation? Well, it's severe upper abdominal pain that often radiates to the back with nausea and vomiting, and patients are often off their food. If multi-organ failure or organ failure has occurred and patients are really sick, then they're going to be hypertensive, shocks and tachycardic, etc. So hopefully I've explained what pancreatitis is. How do we diagnose it? Well, you need to have a clinical presentation that's suggestive of acute pancreatitis, and then it's a blood test. So most hospitals use amylase, although lipase is a bit better. And if it's greater than 3 times the upper limit of normal, then this is kind of pretty much diagnostic for acute pancreatitis. Okay, so hopefully we all now know what pancreatitis is. It's lots of patients have relatively mild pancreatitis and they'll do okay, but there's a small subset of patients that will have severe pancreatitis and be really quite unwell. As for causes, alcohol and gallstones are the most common causes of acute pancreatitis. And in our patient, who had several episodes of right upper quadrant pain and upper epigastric pain, the most likely cause is probably gallstones. The management of pancreatitis is pretty much supportive. You want to try and find out what's caused the pancreatitis and do something about it. So, for example, if it's gallstones causing mischief, you want to try and remove them or unblock any obstruction that the gallstone has caused. But then it's pretty much, fluid resuscitation, correcting hypoxia, nutritional support, kind of good supportive medical care. And if any of these complications occur, which I'm not going to go through just in the interest of time, then patients often require admission to intensive care and can have very, very long admissions to hospital when they develop lots of complications. So severe pancreatitis can be life-threatening and patients can have a really rough time. So we're just going to go on a very quick, just a little sidetrack, just to think about gallstones. So I'm sure we've all seen patients with gallstones, and I hope you'll appreciate this lovely picture. Apologies maybe if anyone had chickpeas for dinner. It looks a bit like chickpeas, doesn't it? It looks pretty horrible. But gallstones are really common, and they're a cause of pancreatitis. So it's thought around 10 to 15% of people in Western population have gallstones, and your gallbladder sits by your liver and it stores and concentrates bile. If your bile becomes supersaturated, then you can form these stones. And the stones can cause a variety of mischief depending on whereabouts anatomically they get stuck. So just to give you a quick overview of the anatomy, your liver, you've got these hepatic ducts, and you've got a cystic duct, and the bile drains from the liver. It can go into the gallbladder, but then the cystic duct joins with the hepatic ducts to form what we call the common bile duct, or CBD. And the common bile duct comes down, it connects with the pancreatic duct, and then it drains into the duodenum. So depending on where the gallstone gets stuck, then it can cause different clinical presentations. I like someone saying it looks a bit like sweet corn. Yeah, ugh, that's grim. So what are the different clinical presentations gallstones can cause? Well, they can cause several. So there's a few different names. So cholelithiasis just refers to gallstones. Cholecystolithiasis refers to you've got gallstones in your gallbladder, and that's really common. And then choledocholithiasis is where you've got gallstones in your common bile duct, and they're more at risk of causing mischief. So what are the presentations patients with gallstones can have? Okay, the first presentation they can have is biliary colic. So this is where a gallstone gets stuck in the neck of the gallbladder. Okay, what does the gallbladder do? Tries to get rid of the stone. It tries to get bile into the duodenum. So it squeezes and contracts, and that contracting gallbladder against that obstructed stone causes a colicky pain. And remember earlier on in the presentation, a colicky pain is pain that's really severe, and then it goes away again. So that's biliary colic. There's not necessarily, well, there isn't any inflammation, there's just pain. And it's typically right upper quadrant pain brought on by eating. And often the gallstone will become dislodged and the biliary colic will go away. If your gallbladder becomes infected, for example, because you've got a big stone stuck in the neck of the gallbladder and bile can't drain, then the bile becomes stagnant and gets infected, then we call that acute cholecystitis. So cholecystitis is where you've got infection and inflammation of your gallbladder. So these patients typically have constant right upper quadrant pain because remember, it's inflammatory, and they'll have raised inflammatory markers. If your gallstone travels down and maybe gets lodged in your common bile duct, it stops the flow of bile. Okay, so bile can't drain. So therefore, you become jaundiced.
your bilirubin rises, and you turn yellow. So you might, and we call that obstructive jaundice. Finally, you can obviously get pancreatitis, and that's where the gallstone blocks the pancreatic duct. And because the pancreatic duct is blocked, all of those enzymes that I was talking about earlier can't drain. So they accumulate in the pancreas and they cause that inflammatory response that we call pancreatitis. And finally, you might have heard of what we call cholangitis. So it's easy to get cholecystitis and cholangitis confused. So cholecystitis is where you've got inflammation of the gallbladder. Cholangitis is an infection of the biliary tree, so the common bile duct, etc. And cholangitis is pretty severe, actually. You tend to get lots of what we call gram-negative bacteria that are really nasty, and patients can become very septic very quickly. And you might have heard of something called Charcot's triad, which is a triad of jaundice, fever, and right upper quadrant pain that suggests cholangitis. So these are the different clinical presentations that you can get with gallstones, and we've already discussed gallstone pancreatitis. But hopefully this is useful for you because this is so common. Lots of patients have problems with gallstones, so it's useful to know a little bit about the underlying anatomy and pathology. Right, let's have a look at our second case. So, sorry, we're running a little bit late, but I'm sure no one minds. No one's off to eat sweet corn after this, so I think we're okay. So let's have a look at case 2. So kind of case 1 was looking at pancreatitis and gallstones. Let's have a look at case 2. Fine. So this is a 53-year-old. He's a man, and he's had kind of grumbling abdominal pain for 3 or 4 days, but it's got acutely worse over the last 4 hours or so. He was unable to get a GP appointment. The pain initially, he says, started on the left side, but it's now spread all over the abdomen. It's now constant, it's severe, and there's no relief really with change in position. He had a bit of diarrhea yesterday, 3 or 4 motions, but no blood in his stool. He hasn't really had any vomiting, but he doesn't feel like eating. He's kind of off his food. He's got gastroesophageal reflux disease, and he's on a proton pump inhibitor, so he's on omeprazole, and he works as a lorry driver. So this is our history. So this sounds like something that's been going on for a couple of days, but is now acutely worsened. Thinking about our examination, well, the first thing to say is that he looks in pain. So that's the first thing you notice, is he kind of objectively looks in quite significant pain. His observations aren't very good. So he's tachycardic and she's febrile, suggesting some sort of systemic inflammatory response. The rest of, from an abdomen point of view, he's very tender in his left lower quadrant, and he's got rebound and percussion tenderness, and he's got some bowel sounds present. So what's everyone thinking about differential diagnoses? Let's have a look. Yeah, so there's a few, quite a range of diagnoses coming up. So maybe have a think. So it sounds like he's definitely got something serious. So thinking about that spectrum of severity, this is a patient that has got physiological derangement, tachycardic, almost a little bit hypotensive, and has got signs of peritonism on his abdominal examination. So he's got some sort of serious pathology. So thinking about some investigations, he's got a bit of a sinus tachycardia, but no ischemic tenderness. He's got nothing on his urine and nothing on his blood glucose. His blood glucose is normal. But what can we see on his erect chest X-ray? Any thoughts? Maybe looks a bit similar to an X-ray that we saw earlier on. Yeah, so he's got pneumoperitoneum. So you can see under his right hemidiaphragm, it's got a raised right hemidiaphragm, suggestive of kind of pneumoperitoneum. So this means, what does this mean? Well, this means that this man has got perforation and he's got air in his abdomen. So something has popped in his abdomen and is releasing air into it. And that would fit with our clinical examination findings that he's got peritonism. He's got signs of kind of an inflamed peritoneum and peritonitis. So what investigation is going to be performed next? Well, we need a definitive diagnosis. So the favorite investigation of all surgical teams, what's going to happen to this man? Well, it's pretty clear. He is going to go through the donut of truth. So the donut of truth is obviously a CT abdomen and pelvis with contrast ideally. So I hope you'll appreciate my medical meme here. I'm quite into my medical memes, but this is the first one that I've included. So, you know, who needs a thorough history and physical exam when you can put your patients through the donut of truth? And truth to be told, a lot of surgical patients that come into hospital will end up having CT imaging because it's the most sensitive to pick up pathology and is good for planning operations. So he has his CT abdomen, and you read the report and it kind of has appearances consistent with acute sigmoid diverticulitis and associated perforation. So that fits with the perforation fits with our X-ray findings. He's got pneumoperitoneum and he's got sigmoid diverticulitis, which quite a lot of you got on the first slide, actually, just from his history. So that was really good. So what's diverticulitis? Well, there's a few words that we have to kind of get in our head. So diverticulitis is when you've got inflammation or infection of diverticula. So what are diverticula? Diverticula are these mucosal protrusions in the muscular lining of the colon. So you can kind of see that in the top image here. You can see these kind of protrusions of tissue in the colon. It's kind of like the sides of the colon, there's kind of little outpouchings. If you've got diverticula, but they're not inflamed, we say that you've got diverticulosis. So I hope that makes sense. So if you've got these diverticula, which lots of us do, but they're not causing you any problem, we just say that you've got diverticulosis. If they become inflamed and infected, then we call that diverticulitis. So hopefully that makes sense. So when your patients tell you, oh, I've got diverticulitis in my past medical history, what they probably mean is they've either had a previous episode of diverticulitis or someone has picked up these diverticula whilst doing a colonoscopy or a CT. So the pathology of this condition is really interesting, and I'm not going to spend a long time talking about it, but it's basically thought the risk factors are mainly age, so it's mainly patients over the age of 50, and the Western diet is thought to play a role. So the fact we eat, a lot of processed meat, low fiber, high fat, somehow contributes to this. So if you look at population studies, diverticula are really common in North America, but really uncommon in developing countries, which have a very different dietary intake. So the epidemiology of this condition is quite fascinating. So this is a disease of Western lifestyle. If you get diverticulitis, you can broadly split it into uncomplicated and complicated. So uncomplicated, you've just got a bit of inflammation in your diverticulum. It's not causing, any crazy problems. But some patients will develop complications. So like our gentleman, he's suffered a perforation because the bowel itself has popped, has perforated due to the inflammatory process. Some patients will develop a diverticular abscess, and some will develop florid peritonitis. So the infection will spread throughout the abdomen. Okay, so we know a little bit about diverticulitis. The clinical presentation is typically left lower quadrant abdominal pain. So the reason it's often left lower quadrant is that most diverticula occur on kind of the left side of the colon. So in the sigmoid colon, that's the most common site for diverticula to occur, although they can occur in the right lower quadrant. And in that case, it can mimic appendicitis. Patients may have a fever. They may develop bowel changes, so alternating constipation and diarrhea. And if they develop some of these horrible complications,
For example, you might feel a mass if there's a diverticular abscess. Just the other thing to say is that sometimes patients can have significant PR bleeding. So if your diverticula become a bit inflamed and they erode through a blood vessel, this can cause significant lower gastrointestinal hemorrhage. So patients present with painless, frank PR bleeding, which in some cases can be really quite severe and significant. So that's often what we call a diverticular bleed. So this is some of the mischief that diverticulitis can cause. So if we're thinking about management, this comes directly from the NICE guidance. So I can't take any credit for this. So you can go and read the NICE guidance. But generally, if you've got mild, uncomplicated diverticulitis, you can be managed in the community. We might consider some antibiotics if there's strong evidence of infection or you're immunocompromised or at risk, and you need a review with some analgesia. You need to go and see the surgical team if you've got any suspected complications, obviously like our gentleman. If you've got severe abdominal pain or dehydration, or you've got things that make you kind of more frail or more at risk of complications. And in secondary care, the first line imaging is a CT. So CT is the first line imaging really for diverticulitis. And you would need intravenous antibiotics, fluids, and management of any complications. So for example, draining of an abscess, or our gentleman will need a laparotomy in order to sort out his perforation. So this is really an overview of the management of diverticulitis. And if you want more information, you can go and read about this in the NICE guidance. So we've talked about acute pancreatitis, we've talked about gallstones, and we've talked about diverticulitis and a little bit about the management and the complications. And we've also talked earlier on in the presentation about some of the history and examination features of abdominal pain. And there's just a few other things I want to finish just before we wrap up. So I hope you found all of this useful. So the other condition I just want to mention briefly, which I haven't written a case on, is intestinal ischemia. Just because this is something that can be quite easily missed, and certainly, I mean, I've nearly missed this. And this is an infographic that comes from EM3, which is a great resource run by emergency medicine trainees in the East Midlands. You can go and check it out. So intestinal ischemia occurs when you have a vascular event that interrupts the blood flow to the gastrointestinal tract. And the one that we really worry about is acute mesenteric ischemia. So acute mesenteric ischemia is basically where you interrupt the blood supply to your small bowel. And what happens if you interrupt blood supply? Well, tissue starts to die, it infarcts, and then it becomes necrotic. So it's a bit like the pathology of a heart attack, isn't it? You block off your coronary artery and a big part of your ventricle dies off and becomes, necrotic, etc. So but kind of the same pathology can happen in your intestine. So patients might have vascular risk factors, or they may have, for example, atrial fibrillation. And I'm sure we're aware that if you've got atrial fibrillation, you can generate a clot that can go up to your brain and cause a stroke. Well, it can do the same thing, but to your bowel. The clot can break off and it can go down to your mesentery and cause a mesenteric event. So the typical clinical finding of mesenteric ischemia is a patient with severe abdominal pain, but the pain is out of proportion to the clinical findings. So when the pain is severe, but when you examine their abdomen, it's not particularly exciting. And you should worry about this, especially in older patients who might present atypically. And the mortality rate of acute mesenteric ischemia is huge. It's around 50 to 80%. And sadly, this will be a terminal event in lots of older patients. So just be aware, if they've got atrial fibrillation, if they've got severe pain, but the examination isn't that exciting, think about intestinal ischemia. And make sure surgeons see these patients. Good, so I just wanted to mention that. You can go read about this if you're interested. It's just something that you can quite easily miss if you don't think about it. Dominique mentioned at the beginning that I've done a few other webinars.
So in the 5 surgical emergencies not to miss webinar, I talk about a couple of other causes of abdominal pain, so testicular torsion, AAA, and ectopic pregnancy. So if you want to learn a bit more about those causes, you can go and have a look at that webinar, although we don't talk about abdominal pain in as much detail. And then lastly, nearly done, you can all breathe a sigh of relief. Just be aware of the older patient with abdominal pain. So be aware of the older patient with abdominal pain. So the problem is that older patients and patients with diabetes or who are immunosuppressed don't tend to present in the classic ways. So for example, they might not have as severe abdominal pain. When you examine them, they might not have the classic signs of peritonism. They won't have the textbook description of cholangitis or of appendicitis. They present in all sorts of funny ways. And as a result, they have a much higher mortality, and they often have delayed surgical intervention, which leads to worse outcomes. So my take-home message to all of this is just be aware of the older patient with abdominal pain. They're much more likely to have something nasty going on. And I would certainly have a low threshold to involve a senior surgical team member to assess these patients, as you don't want to miss a serious underlying condition.